Good morning, everybody.
They're starting. But hi, I'm Jessie Filbert, University of Alberta, Campus Saint-Jean OG, and we're here at the university, we're here at the CNSA conference.
He's associate
Stacy made me do this.
medicine and psychiatry and adjunct professor in psychology and health and human performances at Dalhousie University. So if you could please join me in welcoming Dr. Michael Vallis.
Thanks very much. It's great to be here. I've got 45 minutes. I've got a timer here, so I'm going to get started. And I'll try to kind of cover the bases. 45 minutes is actually not a long period of time to do this. I typically will spend maybe 2 or 3 days with groups. So what you're going to get exposed to, I think, is kind of an overview. What's happening to you today is a very common experience for me, which is I'm often scheduled to present after a very inspirational-based presentation. And it's actually really, really good because what it does is allow us to say that the inspiration is an awesome starting point. That's how most people change, right? If you're going to have a positive reason to change, it's going to be something that's inspiring. But how long does inspiration last? And if you actually follow the evidence, behavior associated with inspirational exposures can be very intense, but very short-lasting. So my talk is about motivation, which is really about the desire to do all the hard work. Think about the following. You're working with an obese individual. Do they want to lose weight? How much do they want to lose weight? How strong, how powerful is that? Incredible. But why can't they? Because that desire doesn't necessarily turn into the day-to-day work that needs to be done to manage one's behavior in this world. So what I want to talk about, in essence, is what's the science behind behavior change? So what is the evidence behind behavior change? And how do we turn the possibility of change into an intervention? Because as health providers, we have to be mindful of the following facts. In the 19th century, the health of our nation was advanced primarily by hygiene. Sterilization, hand washing, because it was infectious diseases that were killing the nation. In the 20th century, health was advanced by biomedicine, diagnostics, interventions, medications. In the 21st century, it appears to us that health will be advanced by behavior change. Because what's killing the nation is cardiovascular disease, diabetes, cancers, all related significantly to lifestyle factors. So this whole issue of lifestyle change is really important for us to embrace. As a psychologist, I've obviously been interested in behavior. That's what my profession is about. That's what my discipline is about. But as a clinician over the years, I'm getting to be quite senior now, what I've realized is that people like me can have almost zero population impact. There's just not enough of us. We cost too much. There are too many barriers for people coming to see us. So although we have some expertise, I would say, and certainly have some value, we're not going to have an impact at a population level. You are. So what I've done is spend less and less of my time seeing patients. I still run an obesity clinic or work in a diabetes management program. But I spend most of my time in the Behavior Change Institute trying to help other people learn evidence-based, theory-driven skills that can be helpful in supporting change. So that's what I want to talk about today. And I'd like to get you interested in this because it appears as though medicine is going to move forward in the following way. It's going to be very collaborative. It's going to be very innovative. It's probably going to take advantage of Twitter and social networking. We're going to use the way in which we work is going to change dramatically. So why don't we get started? I'd like to ask a question. So I want you to give me your immediate response to this. So please do not think about this question. Just blurt out as loudly as you choose your answer to the following question. Is smoking good or bad?
Bad.
Now, for those of you who said bad, I want you to know something. If that leaks out, you will never help a person smoking stop smoking. If that leaks out, that person will not want to see you. That person will feel judged by you. That person will feel criticized by you. That was a very judgmental thing to say. Behavior is behavior, folks. People do things for all kinds of reasons. And by the way, there are 4 good things about smoking. There are 4 benefits to smoking. If you were a smoker, it would bring you positive outcomes in 4 domains. What are they? Socialization, stress management, what's that? Appetite suppression. And remember, smoking is not only a behavior, it's also an addiction. If you're addicted to nicotine and your blood levels of nicotine go below a certain level, you go crazy. You're in withdrawal. What would be more normal than somebody in withdrawal seeking the substance that will normalize them, that will bring them back to a baseline? So that's why I'm here. We have to figure out, as clinicians, how to not be judgmental about behavior. Because I tell you, it leaks out. And honestly, when it leaks out, you cannot help the person. Who are you to tell me what to do? Because the person doesn't hear the smoking is bad, the person hears that they're. So what I want to do is kind of anchor us in the reality of it, because change is kind of hard. Despite the importance of inspirational moments, change is hard. So have a look at this slide. I don't want to make this so database, but I do want to put a bit of a context to it. This is the reality. I would say the potential of behavior change is enormous, but the reality is a little bleak. So medication. You can only count on 50% of the drugs prescribed being used as prescribed. 50%. 1/2 of the medications out there are not being used as prescribed. It takes between $9 and $13 million, 5 and 7 years of research to get a new chemical from bench to bed. Do we need to spend the next 5 to 7 years spending $9 to $13 million on a new drug that people are not going to take? What if we spent that money on adherence? Anybody know about the drugs called statins? What's the attitude to statins? Thumbs up or thumbs down? Thumbs up. I've been in conferences where physicians have made the following statement. We owe it to the public to create an initiative to put statins in the drinking water. So that's what you see around that attitude. And guess what? At 2 years, 80% non-adherence. 80% of people on a statin, which many pharmacology people would say high efficacy, high tolerability, low side effects, prophylactic, not a lot of bad reasons not to be on this drug, 80% stop. Oh, that's nice. What's with that? That's what you and I have to get our heads around. What is with that? And how can we help people make those choices? Even when something as simple as open your mouth and swallow turns out not to be so simple. The DASH diet, if you're unfamiliar with it, is the anti-hypertension, low-sodium diet, the best evidence-based diet out there. More than enough randomized trials showing the importance of the DASH diet in hypertension management. And for 100 people sent to a professional dietitian who are followed in clinical practice, only 20 will actually follow the diet. It's been estimated that 35% of the United States deaths are connected to smoking, poor diet, inactivity, and alcohol use. Ask yourself the following question. We talk about healthy lifestyle, but we need to define what healthy lifestyle means. Really, the contemporary definition of healthy lifestyle is to, not smoke, be at a healthy weight, be physically active, and consume 5 servings of fruits and vegetables a day. Look at the slide. Only 3% of the United States population engages in all 4 of those items. So the reality is a little bleak, and what we have to do is figure out what can we do about that. Because it's not getting any better. These are data, you're probably familiar with the NHANES data. This is sort of the biomedical data that's collected in the United States every couple of years. Well, every 4 years, they have an additional study attached to NHANES, which is called the Behavioral Risk Factor Surveillance Study. And so they've been collecting data on behavior over the last number of decades. And if you look at the rates of unhealthy lifestyle behaviors from 1980 to 2006, you'll see obesity rates are up, Physical activity rates are down. Healthy eating is down. Smoking is about the same. And the only thing that's improved, although not in university campuses, is moderate drinking. So again, that's not so good. So let me ask you some questions. Let's start with what we know. The strongest predictor of future behavior is what? Thank you. Is everybody okay with that? The data is very clear on that. So, what does that say about the likelihood of change? What's that? If you had to make a prediction based on this, what does it say about change? Thank you. As a matter of fact, you can even go stronger and say give up before you even try. What you have been doing will predict what you are doing. Now, I have something to tell you, and I think it's probably really, really good to hear it at this point in your career, because for the rest of us who are already practicing, our patients think that we think that the things we're asking them to do should come easier. Did you hear what I said? Our patients think that we think the recommendations that we're making should come easy. And that's why they're always apologizing to us. They never want to come back and see us when they're not doing well. They only want to come back and see us when they're doing well. The worse they're doing, the more likely they will no-show at a clinical appointment. No-shows are usually an indication that something's going on, but they don't come to see us. Why? Because they don't know what we know. So we as health providers need to communicate this. Because if this is true, then you need to be saying to people, change is hard. We get it. Okay? As opposed to what many people do, which is cheerlead, which is say, oh, it's so great to stop smoking. There's all kinds of things out there that can help you start smoking. Let's go, let's go. But that flies in the face of what you know, which is the strongest predictor of future behaviors, past behavior. So I'm obviously here to talk about promoting change, so I'm very committed to the fact that change happens. But I think you have to be very, very aware of what the starting points are. Because if you are, then you can manage. And isn't this an interesting slide? Look at this. Talk 1 and talk 2. What is the difference between inspiration and motivation? And it differs in 2 domains. 1, external versus internal. And 2, short-term versus long-term. Guess what? Inspiration, powerful. They're both equally powerful. If you have an inspirational moment and you have a motivational moment, you cannot detect the difference in the behavior that immediately follows. Let's go. I'm on track. The question is, how long do I stay on track? From an inspiration, shorter, then longer. From motivation, or longer. Inspiration, I'm inspired by somebody else, like you just experienced, which is great. But if you don't somehow own this, if you don't somehow make this personal, if this somehow doesn't become not about, isn't she great? But what has she fired up in you that you can own and commit to? Because at the end of the day, that's what you're going to be left with, not her. She's going on with her life. And that's a very strong parallel to the clinical world. The acid test of the difference between a motivational intervention and an inspirational intervention is what happens when the intervention stops. And what do you know about every cardiovascular clinic out there, every diabetes management center out there, every orthopedic clinic out there? When the patients stop seeing the clinicians, they stop doing the behaviors. Which tells us that the most of the interventions that we're doing are more inspirational than motivational. So we do need to become more aware. So think about it. If you were working with a smoker, let's take that smoker again, and think about the clinical impulse in the following situation. When the patient says to you, I think I probably should stop smoking, mate. Think about how you might respond. And most clinicians are like drooling. They fall over themselves and they say, oh, that's awesome, yes, yes, let's go. You know what I say? When someone says to me, I think I probably should stop smoking, don't you think? I say, are you sure? Do you really want to? Like, listen to what you just said. I think maybe I should stop smoking. That doesn't sound to me like smoking has become a huge problem in my life. And I gotta get this problem tackled. And I will do a lot to solve this problem in my life. I didn't do that. I heard, I think I probably should. Right? Imagine you're dating someone who says, I think I probably should ask you to marry me. Like, are you really excited? Right, really? I mean, if that was a proposal, like, who in this room would be okay with that? Like, that's commitment? I don't think so. Okay? So, we want to be really mindful. Motivation is important. Take it wherever you can get it. Inspiration, fear, I don't care. But work with it. When you see motivation, that doesn't mean that it's done. That's just, it's there. How do you manage it? How do you nurture it? How do you help shape the right type of motivation? Because it's not so easy. So I want to create very quickly for you the clinical world. What does the clinical world look like? Whose idea is it to engage in the behavior? The clinicians or the patients? It's almost always the clinician. Who does the work? The clinician or the patient? Clinician's idea, patient does the work. And generally, how excited do you think the patient is when the clinician suggests this work? Like enthusiastically, thank you, I've been waiting for someone to tell me to do this for years, this is so awesome. Or, do I really need to do that? So do you think they're kind of thumbs up or thumbs down? Exactly. So how do you motivate somebody? When you're asking them to do something, your idea, they do the work, and they're not particularly excited about that. So just think with that. I want to create that situation with you. Let's play a little game. I want to motivate you, and I'm going to create the clinical world. And I'm going to try to motivate you in one of two ways. I want you to pay attention to the different ways of motivating somebody. Right? So what I want you to do is the following behavior. My idea, you do it. Chances are you're not going to be excited. I want you to work an extra 60 minutes a day for the next 2 weeks. My idea, your work, you're not excited. But look how gentle I'm being on you. 2 weeks! It's totally short. Most of what we iterate with patients, we ask them to do it like forever. But I'm being gentle with you. How in the name of goodness can I motivate you to sort of choose to do that? Because you do the work. You're going to have to figure out where that extra hour comes from today, not me. So how do we do that? Well, here's one way I could motivate you. I would like you to work an extra 60 minutes a day for the next 2 weeks, at the end of which time I'll give you $1,000. Okay, so your emotional tone reaction, thumbs up or thumbs down? Thumbs up? Yeah. Some of you would say, hey, I could use that. That's called positive reinforcement. If that was our world, it would be easier to motivate people. Imagine, get your blood sugars under control, your mortgage is cut in half. That's what that is, right? Get your blood pressure under control, your weight under control, your children's education will be paid for. That's positive reinforcement. Wouldn't it be awesome? But that's not the world. Right? The world looks like this. I want you to work an extra 60 minutes a day for 2 weeks. At the end of which time, I will not throw you down a flight of stairs. Don't laugh. That's our world. I want you to get your sugars under control so you don't have a heart attack. I want you to keep your weight under control so you don't develop diabetes, you don't have cardiovascular disease. We ask people to change so bad things won't happen to them. That's called negative reinforcement. It's hard to get your head around it. The patient looks you in the eye and says, you want me to do all this work so nothing happens? Yeah. And I'm supposed to be excited. Yeah. So just be mindful of that, right? Where is the source of motivation to do that kind of work? Similarly, I need you to know that most of the time, when you see motivation in the clinic, it's actually only motivation for short-term behavior. Do you know why? One of the things that you're going to be asked to do as you embark on your career is you're going to be asked to sort of work in a much more collaborative way. And that's going to mean you're going to have to sort of put on a psychology hat sometimes, a physiotherapy hat sometimes, etc., etc. So here's an important thing around behavior. You need to try to understand why. You want to sort of look, you don't have to be a psychologist, you don't have to go deep, it doesn't have to be psychopathology, right? But there's an expression that guides human behavior, and that expression is the following. If it's not broke, don't fix it. So what does that tell you? about when you see people who are motivated. Why are they motivated? Something's gone wrong. Okay? The most common source of motivation that you will see in the clinic is distress. I'm sick and tired of not being able to get up the stairs. I'm worried about my health. My doctor has just diagnosed me with this and I'm distressed by it. It's January 25th. Do you know how many people are engaged right now in New Year's resolutions? High level of motivation. Why? What is the resolution?
It's saying you're doing something that there's some inadequacy that you have and that you're going to fix.
Exactly. That's right. You've got a problem and you're trying to fix it. And what is the most dominant New Year's resolution? No, weight loss. Why? Because people gain weight over Christmas. And how can you be a human being and go through Christmas without eating more high-calorie food more often, drinking more liquor than you would because of the socialization patterns? And you can't stop them because they're part of human nature. So what you need to understand is when you see motivation, take it anywhere you can get it, but we have to work with it. So when you see somebody who says, I'm sick and tired of not being able to walk up and down the stairs without having a puff, or someone who says, my blood pressure's out of control, my father had a stroke, I'm terrified that I will have a stroke as well. That's great. But you need to ask the question, why will you continue to take care of yourself when your blood pressure is under control? Why will you continue to do these behaviors when you're able to bound up the stairs effortlessly? Because if you don't have that question, you don't have the opportunity to discover the positive sources of motivation. But people have to commit to health, to wellness, and that's hard work. Notice what's in brackets there. It hurts so good. Now, inspiration fires you up. Reality is, oh my God, this is hard. That's why inspiration tends to fail. So you need to take inspiration, whether it be based on something as positive as what you just experienced, or something as negative as getting a blood result that says you have diabetes or you have peanut. And we have to then find some of the positive reasons to do this hard work. All right, and by the way, the strongest predictor of change is what? So we know the strongest predictor of future behavior is past behavior. Do you know what the strongest predictor of change is? And it's a concept called self-efficacy. And self-efficacy is a very important construct for us to become aware of. But most of us assess it inadequately. We ask questions like, how confident are you that you can continue with this? And the answer you get from that is next to useless. Right? You can only assess self-efficacy in a highly specific manner. So the definition of self-efficacy would be a person's confidence to perform a specific behavior in a specific context for a specific time period and in the face of specific barriers. And the confidence judgment, the validity of the judgment goes up as each of those specifics is included. Okay. Now let's get a little bit of optimism going, because change is possible. Here's some behavioral epidemiology study. This is the POTSTEM study. 23,000 people given a lifestyle score between 0 and 4. You get a point if you're a never smoker, a point if you're not obese, a point if you're exercising 3.5 hours a week, and a point if you're eating healthy. Those with a score of 4 had a 93% reduction in the risk of diabetes, 81% reduction in the risk of MI, 50% reduction in the risk of stroke, and a 36% reduction in the risk of all form of cancer. Only 9% scored 4. I like this next study. This is a Japanese study. You can't see that, it's cut off at the top, but what that says is 62,000 people followed for 12.5 years. They gave a lifestyle score based on 6 factors. You get a point if you're not currently a smoker, so you can be an ex-smoker, not drinking heavily, walking an hour a day. If you want to know what the next health behavior that's going to see, wait till the next clinical practice guidelines come out in about 4 years, and you're going to see sleep as a health behavior. And we suck at it. So we're going to find ourselves back in exactly the same situation as when physicians were smoking in the office with their patients. And you look back at that now historically and you say, oh my God, what freaks were those? But just remember, in 5 years, when you're recommending sleep hygiene, and you look at yourself and you say, oh my God, I suck at this, you're going to be in that exact same situation, which is you can talk the talk, but can you walk the walk? It'll be interesting. Educational systems are set up to say, when it comes to rest, I don't care, suck it up. Medical school, they intentionally deprive you of sleep as a rite of passage. I'm serious. It's a socialization. And the attitude of a physician is, suck it up, sweetheart. If you're a real professional, you'll deal with it. I mean, despite what we know about medical errors. Anyway, that's coming down the road. So the daily veggies and a normal weight BMI. If you look at this slide, on the left there, what you see are all the people who had a score of 0, 1, or 2. And they looked at how many people died in the 12.5 years. If you had a score of 3, your risk of death drops 20%. If you had a score of 4, your risk of death drops 30%. Score of 5, your risk of death drops 40%. And if you had a score of 6, all 6 behaviors, the risk of all-cause mortality in this study dropped by over 50% in both men and women. If you had any medical intervention that would save 50% of the lives over 12 years, you would be jumping up and down. And yet, that's what this appears to show us from a large-scale epidemiological study. Now, the only problem with these data is that they're cross-sectional. Do you know what I mean by that? So you're actually finding people doing 6, finding people already doing 5. You and I aren't interested. We're never going to be working with the people that are doing all 6 behaviors because they don't need to see us. So for you and I, it's going to be about change. So here's an interesting epidemiological study called Turning Back the Clock. And these data are from the Atherosclerosis Risk and Community Study. 16,000 participants. The first part of the study is not interesting. They used the sort of classic 4 behaviors, discovered that most people were not engaged in those behaviors. We already know that. What we do also need to know is that 6 years later, they looked at that 95% of people that were not engaged, and they found that 8.5 had become healthy. So you see what you're talking about there is that pink circle on the left. Those people changed. 6 years ago, they weren't healthy. Now they are. We don't know why, but they were. And then they followed them prospectively for 4 years. Those that became healthy had an all-cause mortality risk drop of 40%, and a risk of any cardiac event dropped 35%. This is now about change. So what this tells us is that it's really important for us to get our heads around how to promote change. Final data slide I want to show you, then I'm going to quickly take you through what change looks like. This is a meta-analysis looking at behavior change interventions implemented by either psychologists or general clinicians. So this study answers the question, do you have to have a PhD in psychology and be a behavioral expert in order to implement these kinds of strategies? And the evidence suggests that, in fact, no, you do not. That the effect sizes were roughly equivalent between those 2 groups. And there may certainly be occasions when you want somebody that has skills like me, but there are many, many more occasions when the skills of all of us as more general clinicians. So that, I think, justifies what I would say is the work that we do. So what does this work look like? And what this work looks like is there's really 4 definable skill sets. And I would encourage you to become aware of this. I would also encourage you to develop a strategy to become competent to some degree in these skills. Because this is what if you take the theory on behavior change and the evidence on behavior change interventions, you can say that there's really 4 skill sets. 1, you have to establish a relationship that's based on change. Most of us do not. Most of us are really good at establishing same-based relationships. We're not so good at establishing change-based relationships. So I want to show you what that would look like. And that's where motivational interviewing comes in. You've probably heard of the term motivational interviewing, and it's becoming, I think, what's probably going to be the sort of generic skill set for all clinicians. And it's really about how to have a conversation that's not about you. How to have a conversation that really is about the other person, but establishes a negotiation. Can we work together? I get it, you're going to continue to smoke. That makes perfect sense to me. I understand that. That's your right. What about the fact that it's probably going to kill you? Are you okay with that? That it might be the worst thing that you could possibly do for your health? I get it. You're going to smoke. Go ahead. Feel free. It's your life. But you ever worry that somehow you're like, slowly poisoning yourself? And the patient says, yeah, I do. You say, thank you. Can we work together? You'll give up smoking when you're ready. My job is to do whatever I can to help you get ready. oh, you know what, maybe we could work together. As opposed to, smoking is the most dangerous thing that you can do to your health, and you should stop, you idiot. And you can lose, either include or not the last statement. Once you've got a relationship, you got to get to the behavior, and most people do not come pre-packaged ready to change. So we need ways of enhancing readiness. Once you've got readiness, we need to help you modify your behavior to make change successful. Those people doing a New Year's resolution right now, one of the reasons that most of them will fail is because they're not approaching the behavior change in the correct way. And then once you get the change, you have to keep it going. And the factors that are going to knock you off are going to be more emotion-based. Self-esteem, self-confidence, relationships, and stress. So these are skill sets. And I don't have the time to take you through this now, but I'm going to show you what those skills look like. But again, remember the question I asked you about smoking, and most of you failed it, because you were judgmental and closed and would not be supportive of your patients, and your patients wouldn't want to see you. They would consider you to be, dictatorial and controlling and judgmental and all those negative things. And now we have to sort of understand that by being non-judgmental, that means we just have to understand the reality. And the reality is, change is hard, and in our society, healthy behavior is abnormal behavior. As it turns out, what I can tell you is the following. The human brain is no longer adapted to the environment in which it lives. That's the reason that we're getting fat. That's the reason that we're not eating well. That's the reason that we're inactive. We're not doing anything wrong other than operating on our brains. And the OS 7 of the brain is like this. The basic principle of the brain is to survive. And it survives by balancing pain and pleasure. That dominates all your choices. Apple or apple pie. When the choice should be apple or starve. Now, when we were in a world where we had to hunt and gather our food, you had to work for your food, then the choice was apple or starve. We ate healthier. Same brain, same principle, apple or apple pie. We choose the apple pie. Human nature is to save energy. Path of least resistance. We save calories, escalate.